no hope, you can still go. I never answer to no, man, I still go. Go, 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 yo, go, go, go. Hustle hard, hustle every single day. I'll be making moves till I'm buried in my grave. To the system, I don't wanna be a slave. I've been doing shit my way, or the highway. And in the driveway is a nice range, cause I grind through the climb, I invite pain. You'll never hear me, bitch, nah, I don't complain. Just gotta flip the switch and you can go and obtain anything you want, anything you need. Your mind's got the key ingredient.
Fine needle biopsy overview. Fine needle biopsy, FNB, is a procedure in which a small caliber needle is placed into a mass, cellular material is removed, and a cytologic diagnosis is rendered. It is widely accepted as one of the most useful diagnostic procedures in the evaluation of neck masses. Fine needle biopsy helps to distinguish inflammatory, reactive, or cystic lesions from neoplasms as well as benign neoplastic lesions from malignant ones. Fine needle biopsy is relatively safe, simple, and cost-effective, and it is well tolerated by most patients. However, close attention must be paid to proper technique to ensure accurate results. Fine needle biopsy can be performed with or without aspiration. Both techniques are described here. The more commonly used aspiration technique uses syringe-created negative pressure as well as the shearing effect of the needle to collect material from the biopsied lesion. In contrast, Sagittala et al. Described a technique in which only a bare fine needle without suction was used to obtain material from the target lesion. This non-aspiration technique, also called the Sagittala, pronounced Sagittala, or fine needle capillary method, relies on capillary action to draw the sheared cells within the small caliber needle. Advocates for the non-aspiration, Sagittala, technique believe that grasping the needle hub directly improves operator sensitivity in placing the needle tip within a small lesion. They also believe that less bleeding occurs with the non-aspiration technique, an advantage in the biopsy of more vascular tissue such as the thyroid gland. Studies have shown no statistically significant difference between aspiration and non-aspiration techniques in the successful retrieval of cytologic material. Relevant anatomy: the neck is the part of the body that separates the head from the torso. The Latin-derived term cervical means of the neck. The neck supports the weight of the head and is highly flexible, allowing the head to turn and flex in different directions. The midline in front of the neck has a prominence of the thyroid cartilage termed the laryngeal prominence, or the so-called Adam's apple. Between the Adam's apple and the chin, the hyoid bone can be felt. Below the thyroid cartilage, a further ring that can be felt in the midline is the cricoid cartilage. Between the cricoid cartilage and the suprasternal notch, the trachea and isthmus of the thyroid gland can be felt. The quadrangular area is on the side of the neck and is bounded superiorly by the lower border of the body of the mandible and the mastoid process, inferiorly by the clavicle, anteriorly by a midline in front of the neck, and posteriorly by the trapezius muscle. The image below depicts the anterior cervical muscles. Indications of fine needle biopsy. Fine needle biopsy is the most useful procedure indicated in the evaluation of neck masses. Virtually any mass that is either palpable or identified by an imaging technique can be sampled. Conditions amenable to diagnosis by fine needle biopsy include, but are not limited to, the following: lymph nodes, reactive changes, lymphoma, metastatic cancer, thyroid gland, solitary or dominant nodule, suspected malignancy, lymphoma, and non-toxic goiter versus autoimmune thyroiditis. Salivary glands, benign and malignant neoplasms, lymphoma, inflammatory lesions, and cysts. Cystic lesions of the neck, bronchial cleft and thyroglossal duct cysts. Miscellaneous, parathyroid neoplasms, dermoid cysts, and pterydomosh. Fine needle biopsy should not be used indiscriminately. It should be performed with a reasonable expectation of receiving useful information. Clinically insignificant small nodes, vague indurations, or asymmetries, and other minor abnormalities are not indications for fine needle biopsy. However, note that a negative report can be reassuring to apprehensive patients. Contraindications of fine needle biopsy. No absolute contraindications exist to performing fine needle biopsy of neck masses. However, a mass in the area of the carotid bifurcation may represent a carotid body tumor, and many clinicians are reluctant to biopsy these lesions. Serious complications and one death have been reported following fine needle biopsy of carotid body tumors. These lesions are better identified by imaging. Currently, MRI is the study of choice, followed by contrast-enhanced CT angiography is useful if the diagnosis is obscure or if embolization is contemplated. Fine needle biopsy can be performed without increased concern in patients taking aspirin or nonsteroidal anti-inflammatory drugs, NSAIDs. Patients with bleeding disorders or those on anticoagulant therapy should receive appropriate medical consultation prior to fine needle biopsy. The decision whether to suspend anticoagulant medication must be made on a case-by-case basis. If the anticoagulant cannot be stopped safely, consideration should be given to using the smallest diameter needle possible, limiting the number of passes performed, and using ultrasonographic guidance to identify and avoid small vessels. Anesthesia for fine needle biopsy. The use of local anesthesia prior to fine needle biopsy, FNB, of neck masses is at the discretion of the practitioner. Some authors do not recommend the use of local anesthesia prior to fine needle biopsy, especially for superficial masses. They note that the injection of local anesthetic can cause as much pain as the fine needle biopsy itself. Additionally, infiltration of local anesthesia might make a small mass more difficult to palpate. One author recommended placement of a small ice pack on the overlying skin prior to biopsy. For children, application of a topical anesthetic 30 to 60 minutes before the procedure can reduce pain and anxiety. Other authors argue that the use of local anesthesia reduces patient discomfort and anxiety. Lidocaine 1 to 2% with or without 1:100,000 epinephrine is the agent of choice. The anesthetic is slowly infiltrated through a 30-gauge needle into the uppermost portion of the subcutaneous fat plane and allowed to back-infiltrate the dermal nerves, thus avoiding a painful dermal wheal. Usually, cutaneous anesthesia is all that is needed to provide for a painless fine needle biopsy. Occasionally, deeper infiltration of anesthetic is needed if the target mass is inflamed. A committee report from the 2007 National Cancer Institute Thyroid Fine Needle Aspiration State of the Science Conference provides an outstanding detailed description of local anesthetic technique for fine needle biopsy of the thyroid gland. Equipment for fine needle biopsy. Equipment is depicted in the image below and includes the items listed. Needles. Most authors use 22 to 27 gauge needles of appropriate length with clear or translucent hub. Syringe, 10 ml. If aspiration technique used, larger syringes have not been shown to provide greater suction. Pistol grip syringe holder. If aspiration technique used, this is highly recommended and allows more uniform suction and easier manipulation of the needle. Pad or skin swab prepared with alcohol or iodine glass slides. Gauze sponge positioning for fine needle biopsy. The goal of positioning in a fine needle biopsy of the neck is to provide good access to the target mass with maximum comfort for the patient. In most cases, the patient is placed in the supine position. In fine needle biopsy of the thyroid gland, most authors recommend placing a pillow under the patient's shoulders. This extends the cervical spine and thins the soft tissue over the thyroid gland. The needle is directed somewhat medially toward the nodule, away from the direction of the carotid artery. A thyroid nodule in the posterior part of a lobe can be made more accessible if the larynx is pushed toward the same side. The position of the patient for obtaining a biopsy of the lymph nodes of the neck varies. Nodes become more or less palpable according to the rotation of the head and flexion or extension of the neck. Submandibular gland masses or lymph nodes of the submandibular space may require bimanual palpation. The index and middle fingers of the non-dominant hand are placed in the mouth and push the mass inferiorly while the thumb stabilizes the mass externally. The dominant hand is free to use the needle/holder. Technique of fine needle biopsy. Preparation. Obtain informed consent. Patients should be advised of the very small possibility of infection or hematoma. Label specimen slides with the patient's identification before the procedure is begun. Place the patient in the proper position. Clean the skin overlying the target mass with a pad or swab prepared with alcohol, or povidone betadine, then dry with sterile gauze. Administer local anesthesia, if desired. Aspiration technique. The aspiration technique is shown in the video 1 below. Fix the target mass between 2 fingers of the non-dominant hand. Advance the needle, attached to the syringe, into the mass. Do not apply suction during the advancement. Once the needle tip is within the mass, apply suction by pulling back on the plunger of the syringe. While maintaining suction, move the needle rapidly back and forth with short strokes within the mass. Release negative pressure after sampling is completed and before withdrawing the needle from the mass. Withdraw the needle. The cytologic specimen is within the needle and, perhaps, the hub of the needle. Once withdrawn, detach the syringe from the needle. Fill the syringe with air and then reattach it to the specimen-containing needle. Expel the specimen onto a glass microscope slide as described below. Non-aspiration, Sagittala Technique. The Sagittala Technique is shown in the video 2 below. Fix the target mass between 2 fingers of the non-dominant hand. Hold the needle by the hub between the thumb and index finger. Advance the needle into the target mass. Move the needle back and forth within the mass with short, rapid strokes. Simultaneously, move the needle in a rotary clockwise-counterclockwise motion. Withdraw the needle. Attach an air-filled syringe, with the plunger already retracted, to the specimen-containing needle. Expel the specimen onto a glass microscope slide as described below. Slide application. See the list below video 3. Expel the specimen onto a microscope slide. Keep the needle tip in contact with the slide to allow placement of a concentrated droplet and avoid spraying of the specimen. Spraying of the specimen is undesirable because it can result in desiccation of the specimen. Residual material remaining in the hub of the needle, if desired, can be removed with a needle, endocervical brush, or fine wooden stick and placed on the slide. Smear techniques. The goal of smearing is to provide a monolayer of cells for microscopic examination. Several methods of smearing have been described, the most common being the one-step and two-step techniques. The technique selected depends on the consistency of the specimen and the preference of the individual preparing the slide. One-step technique, shown below. This technique is more frequently used if the specimen is semi-solid or small in volume. Place the specimen at the labeled end of the specimen slide. Hold the specimen slide with the labeled end, and specimen, uppermost. Hold the spreading slide perpendicular to the specimen slide. Hold the lower edge of the spreading slide in contact with the specimen slide in a hinge-like fashion below the specimen. Rotate the upper edge of the spreading slide toward the specimen so that the spreading slide gently covers the specimen. Pull the spreading slide downward over the specimen slide in one smooth motion, with a very slight smearing pressure. Two-step technique, shown below, video 4. The two-step technique is more frequently used if the specimen is more liquid. Place the specimen at the labeled end of the specimen slide. Hold the spreading slide parallel to and at a 45-degree angle to the specimen slide. Place one end of the spreading slide in contact with the specimen slide just below the specimen. Draw the spreading slide just into contact with the specimen, permitting the drop of material to spread along the line of contact by surface tension. Particles of tissue will be concentrated along this line of contact. Then move the spreading slide away from the labeled end to approximately the midpoint of the specimen slide, drawing the tissue particles with it. Quickly lift the spreading slide from the specimen slide, leaving most of the tissue particles at the midpoint of the specimen slide. Hold the specimen slide vertically for several seconds with the labeled end at the bottom, allowing some of the fluid to drain away from the tissue particles. Place the spreading slide perpendicular to the specimen slide and smear the line of tissue particles as described in the one-step technique.